Thank you everyone for joining today's webinar. Today's webinar is Safeguarding Our Future, Lessons from Arkansas on Battling the Syphilis and Congenital Syphilis Crisis. Like I mentioned, please just make sure to remain muted for today's presentation. I have a few other housekeeping items. For those that don't know, hi, Reagan Johnson, pronoun she, her, and I am the Director of Women's Health and Internal Development here at CityMatch. And I work specifically with our task force for the elimination of perinatal HIV and also lead our portfolio of work around congenital syphilis prevention. So I'm really thrilled to be hosting today's webinar, hosted by CityMatch in collaboration with our task force. For the elimination of perinatal HIV. And I'm trying to multitask here as I continue to let people in and lead us through our intro. So thank you for joining today's webinar. Just a few housekeeping items before I turn it over to our wonderful presenter today. So first, please remain muted during today's presentation. You can utilize the chat feature to chat in any questions that come up for you while listening to today's presentation. And then you also can utilize, I believe the Q&A tool is available. If that is available and you see that, you can also use that as a means to chat in any questions as they come up. And then, of course, you can feel free to come off of mute when we move into our dedicated Q&A portion of today's call, which will be at the end of the call after the presentation is finished. The webinar will be recorded, and the recording link will be sent out to all registered attendees once it's posted and available. So you can feel free to share that with your colleagues or anyone in your department, organization that was unable to join us today, or if you would like to revisit any of the content presented on. Our speaker also will have their slides available as well to anyone interested. And then also the last thing I will note is we will be sending out a post-webinar evaluation. So we would really appreciate you taking a few moments to complete the webinar evaluation. It really helps us to ensure that the content that we're bringing to you all is timely and they're emerging issues, and it is good information for you all and what you would like to be learning about. So that provides an opportunity for you to not only provide feedback on today's learning opportunity, but also provide input for future learning opportunities. Okay, so today's webinar, again, Safeguarding Our Future, Lessons from Arkansas on Battling the Syphilis and Congenital Syphilis Crisis. And I'm going to stop sharing quick. I'm going to move into introducing our wonderful speaker for today. And then we will be turning it over to her to lead us through her presentation. So again, just a reminder, I know a few more have trickled in, so please just make sure that you remain on mute for today's presentation. All right, so today's wonderful speaker, we are thrilled to have Mallory J. joining us. She is the Infectious Disease Epidemiology Section Chief and the SETNet Coordinator at the Arkansas Department of Health. She has nearly a decade of experience in maternal health, with the past 3 years focused specifically on infectious diseases impacting pregnant women and their infants. Mallory holds both her undergraduate and graduate degrees in health sciences from the University of Central Arkansas and is currently completing her doctorate in public health at the University of Arkansas for Medical Sciences, with an expected graduation in spring 2026. In recognition of her leadership and impact, Mallory was named to Arkansas Business's 20 in Their 20s class of 2021. She has presented at numerous national and local conferences, including the Association of Maternal and Child Health Programs, the keynote speaker at Child Trends Syphilis Summit, the Arkansas Public Health Association, and various forums within the Arkansas Department of Health and the Centers for Disease Control and Prevention. So thank you so much, Mallory, for being here today to share your expertise and experience with our webinar attendees. And I will now turn it over to you. Thank you so much.
Yeah, thank you so much, Reagan. So let me share my screen. Okay, and is everyone seeing the presenter mode? Everything looks good. Awesome. Okay, again, thank you so much. And I'll be looking over here because I have like 3 screens and it's over here. So I do apologize. But Today we're going to be talking about syphilis and what we've learned in Arkansas, kind of some of the things we've done. I did get this presentation in AmChip, so if you're seeing it for the second time, we do have some information, but it is a little bit of the same presentation. But again, I just want to thank City Match for allowing me to speak today. Here are just my disclaimers and kind of an overview of what we're doing. So we're going to be going over like who we are, how did we get here, what are we doing, and some accomplishments and future endeavors. And really for this presentation, one of the things that I really want everyone here to walk away with, if you have walk away with nothing else, is that syphilis is a maternal health issue. I'll go a little bit more and a little bit later in the presentation, but I really hope that the biggest thing you take from this is all the stuff we're doing in Arkansas, learning more about syphilis and congenital syphilis, and again, when we're in the maternal health space, having syphilis as a maternal health issue. So what I keep saying this Arkansas syphilis crisis. So what am I talking about? This is a graph for a 10-year trend, and I will say I like to tell a story, and I kind of want to go through this presentation talking about how we got to where we are and some things we've done throughout the years. So I think that's important to understanding what we've done and how to implement it in your own state or organization. So kind of going back to 2022, this was a 10-year trend line that we kind of first saw what was going on. And I like to also say when I'm looking at this, looking at these numbers, this is well exceeds the numbers of perinatal HIV during the HIV epidemic. So just kind of show how bad syphilis is when it's surpassing perinatal HIV back in the HIV epidemic. But looking at this 10-year, you can see there was a 562% increase in this 10-year trend. Now, we did a few things in between here. This is kind of before my time in this position, but back here in 2018, we kind of saw our first big spike. So we brought the CDC in, like, what's going on? How do we address this? And so we did some outreach and then again, just meeting with the CDC to kind of figure out what we could do. Then 2019 happened, 2020, and we all know what happened in 2020. We had the COVID-19 pandemic, and you can see between 2020 and 21, our numbers skyrocketed. And though we were in the midst of a pandemic, other things were going on, right? So we implemented the Arkansas law because we were seeing that, testing and treatment is a huge deal in Arkansas, and we weren't getting testing done. So we implemented a law, testing of pregnant women is required, and this just says that required all pregnant women to be tested the first prenatal care visit, third trimester, and if not done, doing it at delivery, if not done during pregnancy. And this is an important law. So again, this happened in 2021, and this kind of snowballs to what we're doing now. So again, just kind of going back to 2022, when this work first started happening, this is just data from the CDC, and you can see the US rate and the Arkansas rate increased throughout these few years. So obviously it's not just Arkansas, it's the United States. And you can see that our rate of congenital syphilis went from 34.5 per 100,000 or 1,000 lab births to 191.9 100,000 lab births. And we've always ranked around the top 10. Now let's jump to 2023. And this is kind of where our journey begins with us addressing syphilis and congenital syphilis. So when I came into this role, I came into it in 2023, and I brought over Surveillance for Emerging Threats to Mothers and Babies, our SETNet, which is a CDC-funded program. And it actually started with syphilis and Hep C back in like 2018, but then Arkansas came on during the COVID-19 pandemic. And we, started doing COVID-19, built our registry, built the SETNet program. And then when COVID started dying down, I became the infectious disease epi supervisor. And I was like, well, what do we focus on now? And my predecessor was like, you need to focus on syphilis. Now, granted, I've worked in maternal health for nearly a decade. I've taught sex education. I've worked in sex education. So I obviously knew about this STI, but I really didn't know about the STI we call syphilis. This is just our SETNet team. We are small but mighty. We have epidemiologists, a data manager abstractor, and our very gracious Dr. William Greenfield. And I say gracious because we all know public health funds are few and far between, and he is just very passionate about this work and has been a big partner with SETNet, and so he helps a lot of our outreach. So when I came to SETNet and I came in this position, I kept hearing, okay, I'm seeing the data. We have a syphilis crisis. We have this funding to do syphilis. What does that mean exactly? And I always like to kind of go back to the basis because you never know what the syphilis knowledge is. And I, for one, learn something new about syphilis every day. And so just kind of overviewing what in the world I'm talking about when I'm talking about syphilis. So this is syphilis. It's a spirochete shape. I actually have the large syphilis in the back of me, or in the back of here, and everyone always says, "Oh, I hear worm," and I'm like, "That's syphilis." But just kind of showing the spirochete shape, as well as it's transmitted sexually, but it can be via blood, but that's very rare. And there's different stages of infection. We have primary, secondary, and tertiary, and I really like this graphic because it kind of shows that, yes, syphilis can live in your body for 10 to 30 years, but when we get to that tertiary phase, that's when people get really sick. We have neurosyphilis, we have ocular syphilis, and this is sometimes when syphilis is discovered in this tertiary stage at your optometrist, or again, when you're having these mental health issues, and it's neurosyphilis. This graph, slide I really like. I don't want to get too much in the weeds of this, but I just think syphilis is a super interesting organism because it can actually change its genetic makeup because it has a slow metabolic activity. So it actually can change its makeup when it's in your body. So your B cells are like, hey, what is this? Let's attack it. And it doesn't want to be attacked, right? It wants to live in your body. So it can actually change its genetic makeup, which I just think is super, super cool. And honestly, you can do a whole presentation on this. But that's what we're here for. But I just, again, want to emphasize how interesting and sometimes complicated syphilis is, but again, not as complicated as we think it is. Now I'm going to go into some quick facts. Syphilis can affect both mom and baby. It can be passed from the fetus during delivery and cause miscarriage and birth defect. They can cause serious illnesses, lifelong disabilities such as hearing loss and learning problems. And I like to highlight this because it is 100% preventable. Again, syphilis in pregnancy can cause miscarriages, stillbirth, or baby's death shortly after. And congenital syphilis is defined in any baby under 2 years of age. And this is a very important statement that I like to highlight and say twice because this is where I like to draw in the maternal health crowd of when, I go to all these maternal health conferences, I go to maternal health meetings, and we talk about postpartum, prenatal care, mental health, substance use, but very rarely do we talk about syphilis. But in our population, these are the moms that are having substance use, aren't getting prenatal care, are having, mental health issues, access to care issues. It's all the same population, but so I think this gap that's missing is this STI and maternal health linkage. But approximately 40% of babies born to women with untreated syphilis can be a stillborn or die from the infection. Again, 40% of babies. So again, you see why this is a maternal health crisis or a maternal health issue. And then babies born with congenital syphilis can have bone damage, severe anemia, enlarged liver and spleen, jaundice, nerve problems, and causing blindness, deafness, and skin rashes. I would like to warn that I am going to show some pictures of congenital syphilis because, again, sometimes I'm a very visual person and I want to show what I'm talking about when I'm talking about these adverse effects to congenital syphilis. Again, it's vertically transmitted. This is a picture of mucus plugs that are all over this baby's body. Syphilis can also manifest later in life, and when babies are starting to get teeth. This is Hutchinson teeth, so that's another way it can manifest. And again, this baby has rashes, and so these are just some manifestations of congenital syphilis. Here you can see they have kind of drawn like the enlarged liver and spleen. And I like to note right here the baby's arm is kind of tucked in because this is very it is very painful for babies. And so you'll see a lot of times this telltale sign of congenital syphilis is the baby's arm like this because it hurts to extend. You have some mucus right here, and again, this rash and issues with the skin, and again, right here, that arm. So again, a telltale sign of congenital syphilis. But then congenital syphilis can look like this. Congenital syphilis can have not manifest when a baby's first born, and it can be born perfectly healthy with no signs or symptoms. I want to tell a story, and I do want to say there is a trigger warning that there is involved infant death. So a few years ago, way after the law was passed, when babies should have been starting to be screened at delivery and first and third trimester, We had a baby born in Arkansas, in rural Arkansas, born a perfectly healthy baby, vaginal delivery, no complications, nothing at delivery. The baby was a little bit underweight, but that's about it. So the mom and baby went home. A few weeks after that, the baby started getting some mucus around the nose. And the mom was like, oh, well, I think, my uncle had the flu, so it must be the flu, and didn't think anything about it. A few weeks later, the baby started developing a really bad diaper rash. The baby went to the pediatrician. They treated the baby with different creams and ointments, and it started getting really, really bad. We actually have a picture of it, but I don't like to share because it is very, very graphic. And I'm talking about the baby's diaper rash by the time it came to the hospital was like a gaping hole and very painful. So the diaper rash, the mucus, and then around 3 months old, the baby started declining. It started to stop eating. It had failure to thrive. And so the mom took it to the ER. When the baby got to the ER, they didn't know what was going on and they transferred the baby to our local children's hospital. When the baby got there, it was put on ECMO and it had about every doctor known to man to come in there. They brought an oncologist in, they brought a geneticist in. All these doctors are trying to figure out what was going on with this baby. And in between all the chaos, someone ordered an RPR, which is a test you do to test for syphilis and congenital syphilis. And within the mix, we finally got our infectious disease doctor to come in. They were like kind of the last doctor, and she looked at the chart and she said, this baby's RPR is on 1 to 256. And if you're not familiar with RPR, that is extremely high RPR, and that means the baby is very, very sick at that point. And despite all efforts, the baby did expire. So I like to tell the story because it just shows how screening at delivery could have saved this baby's life. Because when the infectious disease doctor started looking into was the mother screened, the mother had a first prenatal care visit screening and it was negative. She didn't have a third trimester and she was not tested at delivery. She had okay prenatal care, but she definitely had prenatal care in the first, third, and at delivery, and again was only tested in the first trimester. And if they would have just tested her at delivery, they would have saw her be positive for syphilis because they ended up go ahead and testing her and she had a 1 to 32 RPR. And again, so that was very active syphilis. And again, pass it to the baby, and the baby unfortunately passed away. This is very traumatic, not only for the baby or for the mom, but the whole family and the whole community. And again, I'd just like to say this is a very tragic story, but it just shows that we can prevent and reduce the negative impacts of syphilis with testing and treating. And speaking of treatment, this is just treatment. It's the miracle drug, as we call penicillin. And depending on the stage of syphilis, there's, 1 dose, 3 dose, and of course, the nasty one of the infusion if you have neuro or ocular syphilis. Treating babies with congenital syphilis, this is what we don't want to do, right? Because we want to prevent these babies and test and treat these moms so that they're not born with signs and symptoms and being tested and they are positive. And so this is the baby, if they need treatment, most of the time they have to go to the NICU and spend the first 10 to 14 days in the NICU. Not only is that traumatizing for the mom and baby bond, it's traumatizing for the baby, the mom, the family involved, because then you have the stigma of like, well, why is the baby in the NICU and all this other stuff. And then also the NICU bill, right? NICU is not cheap. And so you're having to go have a baby go and get treatment for 10 to 14 days. I really like this graph because it kind of shows that it's not just Arkansas. When I'm talking about this and we're focused on Arkansas, it's not just Arkansas, it's honestly the whole United States. And you can kind of see how primary and secondary syphilis has gone up over the year. And I just really like this graph from the CDC that just kind of shows the progression of the rates of syphilis among women or women of reproductive age in the past few years. This is the status slide I have because it shows the congenital syphilis reported stillbirths and infant deaths. Looking at data and working in this for a few years, I think the syphilis stillborns are underreported because we don't test moms for stillborn or when someone has a stillborn. A lot of states actually have started adopting this where they're testing, requiring testing for any mom who has a stillborn, and we're looking into that to do that in Arkansas. And so we went over the data. We've seen the adverse effects of congenital syphilis. We heard a story that was very tragic dealing with congenital syphilis. And so when I first started working with syphilis, I was like, okay, well, what's causing the rise? And unfortunately, it's not just an easy answer. But syphilis was actually almost eradicated in the US in the 1990s, and then kind of just sees how much it has increased over the past few years. But it's not just a simple answer. We have systematic issues, we have individual behavior issues, we have implementation issues. So with systematic, we have stigma, we have limited resources, funding, and access to care like prenatal and mental health here, especially in Arkansas. We also have providers not prioritizing sexual health questions. We have inconsistent screening patterns. A lot of states, if you look, you can go on the CDC and see what your state requires for the law, if you have a law in your state. But most of the time, a lot of states are now doing first, third, and at delivery. Some states are doing first trimester. And if you have doctors traveling, getting jobs in different states, that might be lost in translation of what they're doing at the hospital. Individual behaviors, we see a high drug use, as well as dating and hookup apps. We have these apps now where you can just download it and hook up and not have any information, which is really problematic when you obviously are trying to do contact tracing for and get everyone treated, and we don't know the names of the partners. And then, of course, we have everything else going on. We have, this was back in 2023, 2024, there was huge outbreaks in different large cities. We had penicillin shortage, which I think they're actually going through another possible penicillin shortage right now. Here in Arkansas, we had a test tube shortage. And then, of course, the syphilis and STD funding cuts. But obviously, we're public health. We don't just sit around and not do anything. We take the bull by the horns and do something. And so this is kind of where our story begins with the crisis to coordination, what we did in Arkansas. So again, just reiterating, we know the data, we know the adverse effects. We actually have had, babies who passed away in Arkansas. So what do we do about this to stop this very preventable disease? Again, going back to 2021, we set up a law, which again will kind of play in a little bit of, we learned that just doing a law is not all it takes, and you have to do resources and outreach to kind of get people on board. We formed an internal steering syphilis committee, and this is made up of epidemiologists, STD nurses, outbreak nurses, and our disease branch chief. And then my program, SetNet, started building relationships with disease intervention specialists because I truly believe DIS are the backbone of our work. They're the ones who are doing contact investigations, talking to the patients, and they can kind of see and build relationships with their community and know what's going on in their community. So DIS was a big relationship we wanted to build with. We also had carryover funds when we first started SetNet, or first started doing syphilis, where we will kind of go into what we did next, which is our syphilis summit, but we use carryover funds to support our syphilis efforts. And then the SetNet and ID branch looked to increase partners to address missed opportunities in care, and I'll go into the missed opportunities a little later, but our areas of focus was, we decided to do drug use, our patients not receiving prenatal care, and then families with NICU or NICU infants. So thinking about those partners, those are the first kind of partners we made. We first made partners with our DHS, and this is Bonnie. She is a peer specialist and under the substance use branch, and she actually has lived experience. So having her was super crucial as our first partner. And then we also had a partnership with Dr. Young, who's an infectious disease doctor at Children's Hospital, who's very, very passionate about syphilis, and she's been a really big champion for some of the work we've done. And then we have, again, our partner, Dr. William Greenfield, who's our medical advisor, who kind of brings the OBGYN perspective into our work. So kind of going back to the missed opportunities, we first looked at, because again, we want to know what was going on. We had the multifactorial issues, but we wanted to know what was going on. Why are we having a law in Arkansas, but we're still having these, high rates of syphilis and congenital syphilis? And the CDC first did this, and they looked at missed opportunities among mothers delivering infants with congenital syphilis. And when we first looked at this was 22-23, you can see that we have no timely or no testing, we have inadequate treatment, and then we also have reinfection. We redid this recently, and you can see that now we're even increasing to no timely testing, and especially right here, we're seeing a huge increase of reinfection, which means moms are coming in, getting tested and treated, but we're not treating their partners. So then they go back out, have sexual activity, and they're getting reinfected. And sometimes we're not testing on the third or at delivery, and then we're missing these reinfections. And then no adequate or inadequate treatment. So when we first started looking at this, we were like, okay, why is this inadequate treatment? And so when we started looking further into it and talking to our DIS, talking to our nurses, we saw there was a big gap in provider knowledge. Most of these providers have not heard of syphilis since medical school, or they were confused about, when to treat syphilis and how to test for syphilis, reading these RPR, what tests to use. And so we came up with our partner and we wanted to address this. So the first thing we did was we threw a congenital syphilis summit. We had some money and we said we have to do something. So we did a call to action, and our primary focus was providers because we wanted to do, a knowledge-based call to action. And so we had our infectious disease medical advisor officer, who's right here, Dr. Patil, who did the opening. We had Bonnie speak, who was our partner. We had Dr. Young speak. We had an OBGYN speak. And we also had DIS speak to kind of show like, okay, when you send it to the health, your lab results to the health department, what happens after that? So we reached around 115 medical providers. We had one in Central Arkansas and one in Northwest Arkansas because this is our hotspots in Arkansas. So a lot of things came from the Congenital Syphilis Summit. Not only did we reach providers, but we had nurses from different hospitals. They requested presentations to give to their respective hospitals. We had a lot of presentations requested around the state. We connected and presented at the Arkansas Hospital Association because we also learned through talking to providers that it's not just getting providers on board, it's getting the hospitals on board to get this implementation going and make sure they're doing what they need to do. And the biggest thing that came out of this Congenital Syphilis Summit, not only was the increase of knowledge and partnerships, we started the Arkansas Perinatal Quality Collaborative Pilot. So the director of this ARPQC came up to me after this summit and was like, I didn't realize, this was such a big issue in Arkansas. I want to do a sprint initiative. And so we partnered and we decided one of the things we were seeing again was not test and delivery, and our goal was to not have babies leave the hospital not knowing their status and their mom status of syphilis. And so we did 100% of birthing hospitals will implement universal screening of pregnant patients for syphilis during delivery hospital. It's a really good resource guide. Here's the website, and I'll share my slides at the end, and y'all can kind of see all the stuff we did. They had a really good job building this website and our initiative. So we first did baseline. So we just did a sprint initiative. So we started January 2025 and we just ended in July. So some of these slides I'm showing are kind of new information. And so we don't have everything, but we hope to kind of be presenting some stuff at conferences and publishing some stuff here shortly. But we did a baseline back in December 2024. And this is kind of showing the overall characteristics of the birthing hospitals in Arkansas that we're going to implement. And again, this is just talking about the treatment and everything like that for these moms. We also focused on not only birthing hospitals, but we also focused on emergency departments because in Arkansas and many other states, a lot of moms get their prenatal care in the emergency departments. So when we first launched this, we already saw really positive feedback. So we had 22 hospitals participating at this time. We had a few more join later, but we had an OBGYN director at Great River Medical in Blytheville say that this initiative is benefiting their patients. She said, because we initiated the syphilis screening on admission, we were able to catch a positive case. It was initially negative in the first trimester. And then by screening every patient at admission, we were able to get the baby at tertiary care for treatment. So this again just kind of shows we were seeing positive impacts just a month into the pilot. So this is preliminary, hot off the press, of data from our pilot for hospital policy change, because that was one of the things we wanted to do, because we saw that universal screening in the first trimester, third trimester, and universal screening overall was kind of down. And you can kind of see this was at baseline and fully implemented. And one that I'd love to see the most is this universal testing. So we had 5 hospitals when we first started this pilot that had universal screening, so first, third, and delivery. Now we have 18 of the 23 that we had participating. We are still figuring out why the other 5 didn't do universal screening, but it could just be a delay in the reporting. So at this time, again, just this 56.5% increase of universal testing from 5 hospitals to 18. It was a huge win for this pilot. So we also did education throughout this pilot. So we had around 357 participants from 23 birthing hospitals. And this is just kind of showing how they're going to change their practice as a result of attending this activity. And you can see 45% said their activity validated their current practice, but 32% said they're going to revise protocols and procedures, and 36% said they'll change their management or treatment of patients. And some free response from others said this education kind of helped advocate for their patients and ensure testing is done, better understand testing results, increase awareness of warning signs, and improve care. And now they have a better understanding of why certain policies and procedures are in place. We also did a reflection. This was literally just last week, and so it was very informal. They actually are piloting, or the meeting was about their new initiative they're doing with the Perinatal Quality Collaborative. And at the end, we just kind of asked a few questions from the hospitals, and we asked what the biggest barriers were for the pilot and how implementation of testing and treatment were. And what was very surprising was that they said the universal testing was not difficult to put in place. So again, that just shows you, though this law about universal testing and the testing in the first and third, and if not at delivery, has been a law since 21. But we didn't do kind of the back end public health work of educating the hospitals, getting hospitals on board and really educating to get hospitals to do the screening. But then with the partnership with the ARPQC, we have this relationship now. They have the education, and now they're adopting the screening. And then also ACOG came out and also updated their policy and procedures of our recommendations. And so that also, I believe, was a factor. One of the things, again, we have one part down, right? We have the testing, but now we're seeing that treatment is also a barrier. They said that the testing implementation was easy, the treatment was hard. We have a lot of rural hospitals that don't carry penicillin, are not able to give Bacillin in their OBGYN clinics because of the cost. They said treatment cost and access were the biggest barriers. And then one person said universal testing for admissions to labor and delivery was easy. Universal testing in emergency departments were not easy. One said that they feel the cost and availability of treatment is the biggest barrier to providers, especially in clinics, and we are referring them to local health units. So meaning if they have a baby, they're tested at delivery, or they're tested at the first and third, they're telling moms to go to the local health units. Well, you think you just had a baby or you're pregnant and you were going to one appointment, now they're telling you to go to local health unit. That might not be your doctor. You're just showing up to the health unit, and sometimes there's miscommunication of like, why are you here? And so that kind of creates some barriers that we're now having to figure out what to do about. Another thing the hospital said was the desensitization. So pregnant moms can only have penicillin for medication, and if they're allergic to penicillin, they have to be desensitized. Now, obviously, we know that a lot of people think they're allergic to penicillin, but they're actually not. But we did have a case here where they were actually allergic to penicillin, but the hospital did not have the capacity to desensitize, and so then they had to figure out how to desensitize this mom, which delayed treatment. And then another thing was treatment coverage. So they were saying there was some issues with billing, and so that's something else we're looking into with treatment coverage. So again, that was kind of a wrap up of our pilot study. We're still evaluating how many we caught for this testing and delivery. They're still doing their case studies and wrapping up their case reviews. And so we'll hopefully have a report soon. But again, some of the things we've learned thus far is that treatment is a huge barrier, though testing was easy to implement, and as well as, you know, just because you change a policy, it's not just automatically going to be adopted. You kind of have to put some groundwork and things in the background to get hospitals on board and get this implementation plan going. So now we're going to kind of move to SetNet, and that's what the program I'm over. And this is kind of, so you know, we did our outreach with the perinatal quality, and this is kind of more enhanced data. And so we're on year 2 of our grant with CDC, and we're following moms from 22 to 23. And we have just data points from CDC and Department of Health that we're interested, and we do internal medical abstraction. So when we first started looking at syphilis, we just did a pilot study. We just did a sample, or excuse me, a pilot. When we were doing the pilot for syphilis, we just took a sample of moms with syphilis, and we looked at a little bit more granular data. So we only did around 50 of the sample, and so we broke it into congenital syphilis and non-congenital syphilis, and we were looking at substance and no substance use. And we also looked at like prenatal care, reinfection, and missed opportunities, as well as incarceration, homelessness, mental health, and partner violence. So this paper is almost about to be published. It's not published yet, and I'll again share my slides at the end so you can look at it a little bit deeper. But basically, the results showed this. The results showed high rates of substance use, 38%, and reinfection, 42% among mothers, with meth, cocaine, alcohol being prevalent, and these mothers facing barriers like mental health issues, domestic violence, and delays in prenatal care, as well as adverse outcomes. We had 20% of the infants born preterm and 20% with low birth weight. We also on SetNet follow the baby for 2 years, and so on average, looking at follow-up data, we only had around 2 to 3 follow-up appointments post-delivery, which is very concerning to see. But what the study showed, again, this was just a sample of the data. So we're hopefully, once we keep building up our SetNet registry, we'll be able to do a whole, redo this study and have a higher population. So this study underscores the complex interplay of substance use, mental health, and social challenges affecting maternal and neonatal health, and it highlights the need for integrated care models that address these intersecting factors. So because of this study, we again worked with our partner. So we already had DHS, our Human Department of Services partner with Bonnie, and they wrote us in their state opioid grant because we kind of showed like, hey, this is an issue with our moms. How can we help? And this is just kind of our SMART goals for each year. And some things we've done so far, we are collaborating to assess and enhance the capacity of drug rehabilitation facilities across the state to provide testing and treatment services for pregnant women with syphilis and substance use disorders. We're doing outreach campaigns with rehab facilities. We have STI kits going to our DHS partners. We have recurring meetings. And one of the biggest things we've done, we got peer support specialists taking our ADH syndemic training. So that means they're trained now in HIV, Hep C, and syphilis testing and counseling. So they are able to get in places we're not and do this testing and be able to link these patients to care. So that's a super big thing that we've done with the DHS through the opioid grant that they wrote us in. We also partnered with, again, having these babies not get adequate pediatric care, and pediatrics being a key partner that they could also diagnose syphilis and congenital syphilis. We partnered with our Arkansas AAP, and we were selected for a grant recipient of the National AAP just to kind of do some outreach. And this is kind of the outreach we've done so far. We did some Instagram, like, swipe right for your health, kind of like a play on dating apps, and just kind of knowing that testing is private and free at our local health units. We also just did a poster that can hang up in local health units as well as any of our community partners, because we not only want providers to do this testing, we want moms to know that this is what you should expect when you go get tested, so they can also advocate for prenatal care, so they can also advocate for themselves to know that they should be getting tested. So far, this is our social media breakdown. I haven't had any recent numbers, but back in March, April, and May, this was our reach and our links clicked with our social media. So this is a good progress to see. Here are just some other key partners that we've had. We have Arkansas Birthing Hospital, the HPG, which is the HIV planning group. We've partnered with colleges because we also know that we have a high rates of syphilis and all STIs in our college population, with private provider, Blue Cross Blue Shield. We also are now working with the corrections facility. That was a big partner we wanted to get to make sure we're testing and treating these moms in the correction facility, as well as ARMOR, which is Arkansas Mobile Opioid Response Recovery. So this is a van that goes around and gives substance use treatment, as well as can do testing for syphilis. And they actually just got an ultrasound machine, so they can also do some ultrasounds as well. So that's a big partner that has helped us get in communities and places where we're unable to reach. So now we're to 2025. So some of the things we've done recently, not only the Perinatal Quality Collaborative, we've been doing presentations, but we also have working on some policy. So right now we're working on testing at delivery, because again, our law right now is first and third trimester, but we see now through the Perinatal Quality Collaborative, this universal testing is probably what we need. And obviously we see that a lot of our hospitals are already adapting this, but then maybe we can make it a policy, and then it kind of can be a law, and hopefully more, the 5 that didn't adopt it maybe would. We also are looking into stillborn testing. So again, moms who have stillborns, we test them for syphilis. Earlier this year, we had Medicaid expansion for prenatal care. We unbundled Medicaid. So again, that gives an opportunity for more prenatal care visits and really working to get these moms in and get screened. Through the Perinatal Quality Collaborative, we had stakeholders on there, and one of them was Arkansas Medicaid, and they're going to launch a new performance measure incorporated in their longstanding inpatient quality initiative in July, focused on syphilis testing during delivery admission. So that was a big policy update that we just got a few months ago. So again, I've talked about a lot of things we've done, but we're still working on things because, as I said, through the Perinatal Quality Collaborative, we saw that testing is not complicated or universal testing to implement, but now it's the treatment barrier of getting treatment to the patients. We're also doing a point of care pilot because a lot of times, moms come in, they get tested at a local health unit, and then we never see them again, or we can't track them down. So this point of care testing is like testing and treating the same day, so at least they get one shot of bicillin. We're also doing provider education. This is not a future endeavor. We actually did this on Tuesday. This is a picture that we went to our first hospital. We're kind of targeting areas where we have local health units and their hospital, because we obviously see they work a lot together with getting moms to treatment for hospitals that may not have it. This is just a hospital in Arkansas, and this area we have seen we have a high rate of syphilis, and that's why we picked it, but we also have high rates of providers maybe not screening and testing like we like to see. So we kind of have been targeting these areas to kind of just show our face, meet the OBGYNs, meet the ER. And one thing we learned on this was really interesting. So this is a small rural hospital. This is a town around 10,000 people here in Arkansas. And we met the OBGYN who runs the clinic, and he was saying that they implemented the universal screening. They built a good relationship with the health department and their local health unit, and they send their patients to the local health unit to get treated, and they follow up with them, and it's been a really good collaborative. Now, then we go downstairs to the ER, and the ER doctor was like, I didn't know there was a syphilis crisis. So even within the same small hospital, there was this disconnect. And again, kind of going back to the hospital's reflection, was that implementation of the OBGYN and the clinics were easy, but the ER was difficult. And we have seen a lot of states, or a few states and jurisdictions have started implementing in the ER, where if a woman of reproductive age comes in, there's like an alert that talks about syphilis testing, HIV, and Hep C testing. And that's something we possibly looking into, but again, that takes some funding and some coordination. But again, and also just still doing this provider education, going out, and not only doing hospitals, but we want to reach out to organizations like the doula organizations, pregnancy centers, and harm reduction facilities. And again, hope to gain more partners while traveling the state. We actually gained the ER doctors partnership because we showed him, we had a graph or a handout, and he put it up in his doctor's room and said, I really want to collaborate and kind of see what we can do here in my ER. We also are going to do a congenital syphilis review board. This is kind of like the maternal mortality review board, where we pick certain cases and review them and kind of see where this missed opportunity was. We have an internal perinatal disease group. We're doing conferences. And again, we're still doing the SetNet. And I always like to say, at the end of the day, you just got to keep talking about syphilis. And if anyone lets me yap, I do it. Okay, I've done many conferences. I feel like I'm on a syphilis tour right now. Anyone that will hear about syphilis, I want to talk to them, because again, I've been doing this for almost 3 years, and I meet someone just on Tuesday who didn't even know, who's a provider, who their hospital participated in the ARPQC, their OBGYN clinic is implementing this, and the ER had no idea there was even a syphilis crisis. So again, there's this communication channel is something we really want to keep working on. And because I yap so much, things actually have been happening. So I actually presented this again at the Arkansas or the AmChip back in March. And when I was presenting this, Philip's company came up to me and said, "Hey, we're implementing a Pregnancy Plus app, or we already implemented it because it happened in February in Arkansas, where this Pregnancy Plus app was designated just to, well, we have Arkansas resources. So the moms in Arkansas open the app and they can have resources here in Arkansas, and they had nothing about syphilis. So I worked with them to kind of get this on here. So now in the app, when moms are looking, a headline will pop up that 158% increase in congenital syphilis, how to protect your baby. And this kind of goes through. There's also in the app, you can see what's expected. And on the first and third in a trimester, it talks about syphilis or STI, HIV, and all the STI screening. So that was a really big great opportunity that I wasn't even searching for. I just was talking about syphilis, and again, the Phillips have been developing this, and of course, we did not have STIs in the talk because this app was already developed, and again, working with them to kind of get this implemented in the app was a big success. So again, this was a lot of information, and I'm gonna have my contact at the end to talk about anything, because again, we don't have it all figured out, but as I like this meme of you miss 100% of the shots you don't take, because sometimes, that's what it is. If you don't try things, syphilis is complicated, but it's also not. So it's like, what's gonna work? What's gonna stick? What's gonna get these moms and babies in to our testing and treatment, and to hopefully see what we saw in the 1990s, which was eradicate syphilis. So again, there's much more to figure out when it comes to congenital syphilis. Congenital syphilis is entirely preventable, but we have to do something. And Arkansas can provide a map of community-driven system-wide solutions. But all states need to prioritize testing, early outreach, and coordinator care. And again, it's time to make congenital syphilis, once again, a condition of the past. And here's my contact information. And this is also our QR code to the dashboard, and I will now take questions.
Great. Thank you so much, Mallory. That was a wonderful presentation. I think we can kick off the questions. Someone asked, what is the main source of funding currently, and has that ever become an issue where it became difficult to pursue certain efforts in syphilis prevention and intervention?
Yes, that definitely. So right now we have two kind of funding sources we do, or a few funding sources in Arkansas. So I'm with SetNet, we do, that's kind of where our outreach is being able to be funded through. And so we're kind of using that because the outreach in so facto gets people testing, and then we see this enhanced testing and treatment, which is enhanced data, so we can know what's going on and be able to track this. We also have the Peach Grant in Arkansas. That's kind of where most of our STDs happen. And then we also have been doing a syndemic approach, so we're able to use like the HIV funds, as well as things like Ryan White and Medicaid rebate dollars. Obviously, those are all decreasing, and so a lot of times right now we're kind of having to think outside the box with things that are not with funding, like the Arkansas Perinatal Quality Collaborative. That didn't cost us anything, but the Arkansas Perinatal Quality Collaborative, they kind of took on that. So there are things you can do in partnerships that you can make that are not to do with funding, and that's kind of what I think where we're heading to, right? We're trying to get these partners that, like the opioid grant, they had this grant, they wrote us in there. So that was an opportunity where we didn't have to have the funds, but the opioid grant got funded, and that's how. So really just plugging in and finding that funding, because we know right now it's, up in the air with a lot and decreasing all over the United States.
Great, thank you. Have there been any bureaucratic limitations? If so, how did you work through them?
Right, yes. So great question. So right now, and I'll tell you what we're doing. So there's always stigma, especially in Arkansas. We live in the Bible Belt. We don't have sex education. We have a lot of policies. We have limited reproductive access. So when you package it like it's just syphilis and we're talking about sex and stuff, that's obviously very stigmatizing. But how we're approaching this is a maternal health issue because it is. So our governor has really been focused on maternal health, and so that is how we're packaging this. And because it's affecting moms and babies, and so that's kind of how we've been able to navigate and kind of, we have that story that we tell, and that's been really impactful to kind of show what we're talking about. And when we say like syphilis, like this has negative effects on the babies of Arkansas, and that kind of has been able to kind of get past this bureaucratic issues, is going in like a maternal health approach, which it is.
Great, thank you. Are there any more questions for our speaker today? You can feel free to use the chat, the Q&A tool, or if you would like to come off of mute and ask your question. What has been, and I'm just going to ramble off another one that came in through the Q&A. Thanks for all of your great work. What has been your best avenue in connecting with physicians in this process?
Right. So it has been using the resources with the internal steering committee. So most of the time, at your health department organization, you already have people who have partnerships with different people. And so I really have been like, hey, here's the problem. Who do I talk to? So again, Dr. Greenfield, who is our OBGYN, our medical director, I used him as his resources. I've used Dr. Young, I identified her, which she was already working with our STD nurse. So they had a relationship. And so again, just asking like, what partners do you have? And most of the time in your agencies, especially health departments and state health departments, your nurses, your providers, they already have like a circle of providers, and that's kind of how we've been doing it. And then this provider education, like we use our infectious disease prevention nurses to kind of get our foot in the door, and then we're introducing ourselves to OBGYNs, ERs, as well as the Arkansas Perinatal Quality Collaborative. A lot of states do have their perinatal quality collaborative, so I definitely see if you have that in your state and reach out to them to see how you can partner.
Great. There's a question in the chat. Have you worked on changing legislation to mandate testing at hospitals, or are you just trying to convince them that it's the standard of care?
Yes, so that was what we did in 21. So we actually did do policy, we changed the law, but we're not like an enforcer, right? We're just the Department of Health. We don't have like enforcement or any like legal capacity. So it was more of like educating the providers, because it is a law in Arkansas that they're supposed to test and treat in the first and third trimester. But now we saw that like that didn't work because they still weren't doing it. And even when we did some education, it just wasn't, I don't know what it was, but like I said, with the Arkansas Perinatal Quality Collaborative, this like the education they made, the connections they already had with these hospitals, that was a big, because they were already kind of like their partners had already bought into it, and now they're like, oh, here's this syphilis thing. And I think that was really a key to getting these hospitals to implement this, because they're like, oh, okay, now we understand. And they had like the trusted partnership with the Perinatal Quality Collaborative. And so at this point, we are hopefully going to change more laws with like testing and delivery. But again, we're seeing that it's the public health approach of implementation resources to help these hospitals do it. And that's how, when they did the universal screening and adopted it.
The next question we have is, what would be a good first step to get these efforts moving if we're starting from square one?
So great question. So square one is doing it internally. So again, I keep implementing that STIs over here, maternal health's over here. So just working together to first say, getting the maternal health and the STD folks at the same table would be the first step. And then figure out what data or what's going on in your state. If you have epidemiologists or your state health department or whoever, most of the time, like we have a dashboard, and I'm sure most state health departments have some type of dashboard or data to look at your data, what's going on. Like most of the time, substance use mental health is the same thing, but there might be something going on in your state that's different from Arkansas. So I think first steps would be forming an internal steering committee, because that kind of shows you what's already going on and the kind of the gaps, which again, here in Arkansas, it was that maternal health is over here and STDs over here, and the gap wasn't bridged, but now it is, and we are being able to do all this really good work.
We have a few minutes left on the call, so please feel free to chat any last minute questions in. I also did put the post-webinar evaluation in, so if it's fresh in your mind and you want to fill that out. Mallory, a question I had was around integrating or involving individuals with lived experience into the process. And I know from our end for City Match, we've had a really difficult time integrating those individuals into this work and finding them and creating this cohort or peer-to-peer space. Can you talk a little bit about your team's experience with that and what you have found worked, what didn't work?
So that's a great point because we obviously that's a huge thing that we need, right? We need those advocates. Like in a lot of times, so with our HPG group, which is HIV planning group, we have people with lived experience with HIV. But and I don't know the answer to this. I don't know if it's the stigma, but like getting people to talk about syphilis, especially with pregnant moms or like babies with congenital syphilis, it's just we've always hit roadblocks. It's been very, you also kind of, because we've had moms who have lost their babies, but we don't, they have to be careful with that of like, just re-traumatizing the mom. And if they're not ready to speak, and again, syphilis is so stigmatized in Arkansas. So we're having a hard time identifying people who could be kind of like an advocate. But what we have done is kind of say, okay, what do we see? We see moms who use substances. So now we have identified peer specialists through DHS that are lived experiences with using drugs in pregnancy. So though they don't have the syphilis aspect of it, they have that aspect. So really kind of working around to maybe not syphilis, that they have lived experience with syphilis, but they have other lived experiences. But we are still working with our HIV group to kind of identify if they have partners. But then again, this bureaucracy of, a lot of times some of the partners are like sex workers and things like that, which unfortunately, those would be great partners, but just in the climate, we're unable to do. But again, just kind of working and figuring out kind of what everyone's in public health, figuring out what to do with limited resources and kind of thinking outside the box.
Thank you. That's very, very helpful. Great. Well, thank you so much, Mallory, for joining us. This has been a really wonderful presentation. Like I mentioned before, I'll be sending out the recording link, and then Mallory has offered to share her slides as well. So I'll send those out to folks as well. And if you want to get in contact with Mallory, she did share her contact information. I'll make sure to share that in my email to you all as well. Thanks, everyone, for joining us today. And again, thank you, Mallory, for your
Yes,
time
thank you
today.
so much for letting me speak today. Thank you all.
All right, everyone, have a great rest of your week. Thank you so much.